The history of fibromyalgia. You sometimes hear fibromyalgia referred to as a fad diagnosis or new disease, but the truth is that fibromyalgia is far from new. It has centuries of history, with multiple name changes and discarded theories along the way. While it hasn't always been accepted by the medical community, and today its acceptance isn't universal, fibromyalgia has come a long way. And current research continues to offer proof that it's a very real physiological illness. Back to the beginning, 1592 to 1900. In 1592, French physician Guillaume de Bayeux introduced the term rheumatism to describe musculoskeletal pain that didn't originate from injury, a broad category that included conditions like fibromyalgia, arthritis, and more. Over time, physicians began to differentiate more, using terms like muscular rheumatism for pain-related conditions that didn't cause deformity. In 1815, Scottish surgeon William Balfour noted nodules on connective tissues and suggested inflammation might be the cause of tender points and pain. He was also the first to describe tender points, which would later become significant in diagnosing fibromyalgia. Decades later, French doctor François Vallée used the term neuralgia to describe referred pain from tender points traveling along the nerves, reflecting evolving theories of underlying mechanisms. In 1880, American neurologist George William Beard coined neurasthenia and myasthenia to describe widespread pain, fatigue, and psychological issues, attributing them to stress. Early 20th century, fibrositis emerged. In 1904, British neurologist Sir William Gowers coined the term fibrositis. He described symptoms familiar to today's understanding of fibromyalgia: spontaneous pain, pressure sensitivity, fatigue, sleep disturbances, cold sensitivity, and symptom aggravation with muscle overuse. His suggested treatment was cocaine injections, used medicinally then as an anesthetic. Fibrositis, fibro meaning connective tissue, itis meaning inflammation, gained traction partly due to a later study, but flawed, supporting the inflammation theory. In the 1930s, interest increased in muscle pain from trigger points, and pain pattern charts appeared. Anesthetic injections were a common treatment. In 1936, fibrositis was reported to be the most common form of severe chronic rheumatism, accounting for 60% of British rheumatic insurance cases. The concept of referred muscle pain was further validated, suggesting involvement of the central nervous system and introducing the term myofascial pain syndrome for localized pain, possibly explaining widespread fibrositis symptoms. Wartime shifts and recognition. During World War II, doctors noticed that soldiers often displayed fibrositis symptoms without inflammation or physical degeneration, symptoms linked to stress and depression. This led to the label psychogenic rheumatism, considering fibrositis a chronic psychoneurotic state. This era marked the enduring debate between physical versus psychological causes. By 1949, fibrositis had made it into reputable medical literature. A chapter in the textbook Arthritis and Allied Conditions stated that there was no longer any doubt concerning the existence of such a condition, citing possible causes like infection, occupational or traumatic factors, weather, or psychological causes. Descriptions remained broad, typically involving fatigue, headaches, and psychological distress, but still often omitting poor sleep. Towards modern definition, the first description closely resembling modern fibromyalgia came in 1968 from Eugene F. Trout. He noted female predominance, widespread aching and stiffness, fatigue, headaches, colitis, poor sleep, personality traits, worrywarts, tender points, and regional pains, including axial skeleton and all four quadrants, mirroring today's diagnostic framework. In 1972, Hugh A. Smythe, a key figure in fibromyalgia history, presented a textbook chapter viewing fibrositis as a widespread condition, distinguishing it from myofascial pain syndrome. He emphasized poor sleep, detailing patients' disrupted sleep patterns, and unpublished EEG findings showing dysfunction in deep sleep stages 3 and 4. He also highlighted non-restorative sleep, trauma, and emotional distress as symptom triggers. Subsequent studies confirmed sleep abnormalities and showed that sleep deprivation can replicate fibromyalgia-like symptoms in healthy individuals. Smythe was involved in further research defining tender points in diagnosis and listing symptoms like chronic pain, disturbed sleep, morning stiffness, and fatigue, all of which informed for a clearer name continued. Fibrositis evolved into fibromyalgia, meaning connective tissue, muscle, and pain, reflecting a shift from inflammation towards muscle and pain-focused understanding. However, the condition remained elusive. Research breakthroughs and formal recognition. In 1981, Muhammad Yunus led a pivotal study confirming that individuals with fibromyalgia had significantly more pain, fatigue, sleep issues, tender points, and symptoms like subjective swelling, paresthesia, and overlapping conditions, IBS, tension headaches, and migraines. This established a distinct symptom cluster that allowed fibromyalgia to be identified as a syndrome and offered the first diagnostic criteria differentiating it from other conditions. Yunus further explored overlaps with primary dysmenorrhea, IBS, tension headache, and migraines, initially hypothesizing muscle spasms as the cause, but later theories shifted towards central sensitization. Since then, research has accelerated, improving our understanding through these developments. 1984, higher fibromyalgia prevalence linked with rheumatoid arthritis. 1985, first controlled study of juvenile fibromyalgia. 1986, drugs affecting serotonin and norepinephrine showed effectiveness. 1990, American College of Rheumatology published official diagnostic criteria, widespread pain plus tenderness in at least 11 of 18 tender points. 1991, development of the Fibromyalgia Impact Questionnaire for clinical assessment. 1992, discovery of low growth hormone levels in patients. 1993, findings of central sensitization and hypothalamic pituitary adrenal axis abnormalities. 1994, elevated substance P, pain messenger, detected in cerebrospinal fluid. 1995, U.S. prevalence study, fibromyalgia affects about 2% of the population. 1995, first SPECT brain imaging showing abnormal blood flow in fibromyalgia patients. 1999, first evidence of genetic predisposition. 2000, coining of the term central sensitization syndromes in a review. 2005, American Pain Society published first treatment guidelines. 2007, Lyrica, pregabalin, became the first FDA-approved treatment in the U.S., followed by Cymbalta, duloxetine, and Savella, milnacipran, in 2008 to 2009. As research continues, newer lines of inquiry include potential inflammatory involvement of the fascia, discovery of extra pain-sensing nerves on blood vessels, small fiber neuropathy, immune system abnormalities, including possible autoimmunity or immune markers, and efforts to define fibromyalgia subgroups to tailor treatments and develop objective diagnostics like blood tests or imaging. Fibromyalgia still lacks universal recognition in the medical community, but as research increasingly validates its physiological basis, the condition gains credibility, offering those affected greater understanding, respect, and more effective treatment options.